Hello and welcome, friends, to a very special virtual event which is going to set the benchmark for coming months, coming years when we talk about digital transformation for empowerment of people. I, Shafqat Goswami, welcome you all at a 3-day virtual digital transformation summit organized by GovConnect, an APAC digital news network, and being hosted by Department of Electronics and IT, Government of Odisha, and co-hosted by Moderator Smart Cities Limited. It's my honor to welcome all of you who have joined us virtually, all the speaker, eminent delegates, and who will be part of this 3-day discussion on three aspects of making a difference in people's life. Those three aspects are healthcare, digital intervention for governance, and to bring urban transformation through smart cities program. Today, we have a specified theme on healthcare, how the healthcare technology, healthcare policy, healthcare paradigm can be looked upon in the present crisis of pandemic and the new world order. And for that, we have two dedicated sessions where we'll have policymakers, thought leaders, industry leaders, health tech leaders, startups, innovators, and experts who will be discussing on various aspects of quality healthcare. And tomorrow, we have a day-long session on Digital India, where again we'll have policymakers, the governance leaders from various parts of the country. And day after, that is on 10th of October, we'll have a dedicated session on smart cities. There we'll have smart city CEOs, smart city commissioners, as well as tech companies who are providing solutions for urban transformation. Let me also inform our August gathering that we have got more than 80 plus speakers in these 3 days of conference. It's all happening virtually thanks to the pandemic. And we all are using digital interventions like more than ever we have ever used in our life. And also, we will be having a lot of question answer between the sessions, and a lot of people are already asking us questions. So we'll be taking all that. But before that, let me welcome all of you again to the first day of Virtual National Digital Transformation Summit being organized by GovConnect and Apple Digital News Network and hosted by Department of Electronics and IT, Government of Odisha, along with Moradabad Smart City Limited. First session of the day is leveraging emerging technologies for effective public healthcare service delivery and building resilient and sustainable infrastructure of the future. I must say this is one of the important part of healthcare ecosystem at present time. What are the new policies? What are the existing policies? How those policies can be effectively implemented in the new world order during the pandemic and post-pandemic. For that, we have galaxy of speakers. They're the healthcare leaders from various aspects of healthcare ecosystem. We have with us Dr. Nitin Madan Kulkarni, Principal Secretary, Department of Health and Family Welfare, Government of Jharkhand, will be joining us shortly. We have with us Professor Ravi, Director and CEO, All India Institute of Medical Science, Rishikesh. Thanks for joining us, Professor Ravi. We welcome you. We have with us Dr. T. Arun, Principal Secretary, Health and Revenue, also the District Magistrate of Puducherry and CEO of Puducherry Smart City Limited, UT of Puducherry. Welcome, Dr. T. Arun. I request Dr. T. Arun if he can unmute himself. Yeah. Dr. T. Arun, welcome
Good
for
afternoon,
joining
sir.
us today.
Good afternoon,
Yeah.
and it's a honor and privilege to be with all the.
Great. We'll be shortly joined by Dr. G. Dewan, Director, Health Services, Department of Health and Family Welfare, Union Territory of Chandigarh. We have with us Sunil Kumar, Head Healthcare and DDG NIC. We welcome Mr. Sunil Kumar.
Thank you.
We have with us Dr. Shafqat Khan, Officer on Special Duty, Department of Health and Medical Education, Union Territory of Jammu and Kashmir. We welcome Dr. Shafqat. Thanks for joining us.
Thank you for having me on this session. Thank you very much.
Thank you so much. We are also joined by Dr. Abhishek Roy, Head SeMT Department of Personal and Administrative Reforms and eGovernance, Government of West Bengal. Welcome, Dr. Roy. I think Dr. Roy is with us. I think there's some technical glitch. I'm part and parcel of technological intervention. We have to live with that. Let me also introduce you Mr. Jay Sirin Jairaj, Senior Director, Health Services, Asia Pacific, Oracle Corporation. Thanks for joining us, Dr. Mr. Jairaj.
Thank you. Pleasure to be here.
As I was saying, that the name of this session is leveraging emerging technologies for effective public healthcare service delivery and building resilient and sustainable infrastructure of the future. So, what is the viewpoint of the leader who are transforming healthcare ecosystem across the world? That is Oracle Corporation. I request Mr. Jayasarin Jairaj, Senior Director, Health Sciences, Asia Pacific, Oracle Corporation, to give a presentation on their thoughts on leveraging emerging technologies for effective public healthcare service delivery and building resilient and sustainable infrastructure of the future. The first presentation of the first day of Digital Transformation Conclave 2020. Over to you, Mr. Jairaj.
Thank you, Souvik. Are you able to see my screen?
Yeah, we can see you, but I think when you start the presentation, then screen sharing option has to be there.
Yeah.
In your
Uh,
in the
I'm
bottom
sharing.
of your screen, in the bottom of your screen, there is a screen sharing option.
Yeah, I already started sharing.
Yes, now we can see your presentation. Yeah.
Thank you and good afternoon, all of you. So I'm just going to make a quick presentation to really talk about National Digital Health Mission. What are the technology interventions that can really help to scale NDHM across India, and what Oracle is kind of doing in this space. So that's broadly what I'm going to kind of talk about. Now, if you look at digital health in Indian context, these are really good times. Since 2017, when we kind of rolled out the national health policy, there has been a lot of progress in terms of digital health. In fact, 2019 National Health Authority has been set up, and subsequently we kind of rolled out National Digital Health Blueprint in the last October. In fact, National Digital Health Blueprint really provide a very comprehensive set of architecture to really deploy federated health information architecture at the country level. And then very recently, the Prime Minister kind of rolled out National Digital Health Mission. If you really look at what is the National Digital Health Blueprint is really talking about, it has 5 key layers in terms of architecture. In fact, it's talking about infrastructure, the data hubs to really kind of store data. What are the key technology building blocks, for example, like health information exchange, concern manager, how do we anonymize the data? And then there are a lot of applications on top of it. For example, like wellness applications, telemedicine, emergency care applications, all of that. And then how do we deliver all these services through access and delivery mechanisms? So these are the 5 key layers National Digital Health Blueprint really talking about. Now, if you look at NDHM, it has been launched August 15th by the Prime Minister. It really has 5 key elements in terms of the building blocks it's really talking about. One is health ID. So every citizen will be able to have a unique health identifier. Irrespective of which hospital the patient goes for a treatment, he should be able to link his personal health record, electronic health records with the health ID. And similarly, NDHM is also planning to build a doctors registry across the country. Today, we do have several registries, but I think NDHM will become an overarching kind of registry provider to really kind of connect all the doctors across the country. Similarly, it will also have a health facility registry. It will store all the healthcare providers' facilities across the countrywide. And it will also has 2 key components. One is personal health record, which a citizen can view it. There is electronic health record, which doctor can view it as well. And then the EMR, which is the electronic medical record that is stored at the hospital level. So clearly, it will become an integrated digital health infrastructure, which will connect all the various healthcare providers and provide a very strong interoperable healthcare platform for the country. So that is what is really National Digital Health Mission is all about. Now, if you look at why this is really important for the country, right? One is today, if you look at in India, there is no single or unique view of the patient and provider. If a patient goes from one hospital to another, the hospitals cannot access the patient's health records because the patient IDs are different. There is no mechanism to share data between healthcare providers. There is a lack of care coordination between hospitals. We do not have any seamless process to enable the data transfer across these health entities. And if you look at other dimension, today we only have about 22% of the information is available about the previous visit. So whenever a patient goes to the doctors has very little information about the patient's past conditions, medical history, what the patient is allergic to. Even discharge summaries are not available, especially when a patient is referred to one hospital to another. We do not have electronic exchange of discharge summaries. Similarly, for example, like emergency departments, whenever there's a patient with an accident is admitted in a hospital, how can the doctor look at the patient's past history, medical history, all of that? So that is really a key need why we need to kind of look at NDHM as a very important pillar to enable this electronic exchange of data. Now, if you look at our country, it's largely a referral-based mechanism wherein the patient moves from primary care to a secondary care to a tertiary care. And every time, if you really look at patient data, it is getting siloed. Now, what is the NDHM is trying to attempt is actually to create a unified patient medical summary in a federated model, which will really help to improve the clinical outcomes. That is really the end state we really want to kind of get out of this particular initiative per se. So you can really see at each of these levels, whether hospital, lab, or general practitioners clinic, or nursing home, or health screening, we deal with a lot of different healthcare applications, and each of them store data in a different ways. So that is where the challenge in terms of building the interoperable platform to create a seamless data exchange is very, very vital. Now, if you look at most of the states today, the lot of the focus is actually on the point of care automation. So most of the districts and states now we have the hospital, information systems to automate inpatient, outpatient modules, primary care, to some extent on the community workers' point of view as well. But clearly, the direction that we need to move is actually to create a healthcare information exchange, wherein we can really make this data move across the different entities and create a unified view. And then we can actually have the secondary use of data. Once we really have this information available as part of the NDHM or exchange, both at the state level repositories as well as the national level exchange, then we can actually do population health analytics, we can do health economics analytics. Today, a lot of the policies that we make, there's very little evidence to support. Now, when we really kind of look at from NDHM, when it really implemented across the countrywide, this is exactly what we'll get. We'll have very holistic population health measurements to really look at what are the trends, what are the key disease areas. Even if you look at COVID, how do we really make sure the data is available instantly? So that's where electronic disease surveillance is really important. So all of these will be enabled once we have this platform kind of rolled out. There is also, in India, we use these terms very often, EMR, EHR, PHR, but there is a clear difference in terms of definition. EMR is actually electronic health record that is viewed by the clinician within one single health facility. Today in India, what we have in most of the private hospitals and also the government hospital is actually the EMR. It's a detailed record which can be viewed by the doctor. But what we want to really achieve out of NDHM is actually electronic health record and personal health record. So electronic health record is an aggregated summary record which will really aggregate data across multiple health facilities where the patient is getting treated, and which will be again viewed by the doctor. That is what is actually EHR. And PHR is actually, again, the summary record, which is aggregated record across different health facilities, which are viewed by the patient themselves. Now, all of these three things, EMR, EHR, PHR, will be through a health information exchange that will really facilitate the electronic movement of data across all these different building blocks that we really talked about. So the EMR is a detailed record, EHR and PHR is a summary record, which is understandable by the doctor as well as by the patient. So clearly, if you really look at, if you have to do this successfully implemented across both state at the national level, what are the challenges one have to address? One is, how do we solve these patient identification issues, right? Every hospital has a different medical record number. So how do we really identify the patient uniquely? Similarly for the providers as well, because the doctors also consult multiple health facilities. At each facilities, they may have different credentials. Then how do you identify the providers uniquely is again one more big challenge that we have. Again, in India, if you really look at the health system evolve over a period of time, we have a lot of different standards. Some hospitals follow HL7. Some hospitals do not follow any standards at all. Some hospitals have very basic set of way to kind of store data. So when we really have to build an interoperable ecosystem, how do we really going to handle these different messaging standards? Similarly for terminologies as well, right? A lot of hospitals follow ICD. Even though the government kind of standardized on SNOMED city, still we see a lot of hospitals follow different terminologies. Even some hospitals, I would say, even we do not have any terminologies as well. So how are we going to normalize different terminologies, right? And then how do we create a unified longitudinal patient record? That is exactly the challenge that we really have. And then how do we ensure security and privacy and concern management, right? Because whenever the doctor wants to view the patient record, does he really have a consent? And in this case, it could be electronic consent, which is again compliant to the Government of India standards as well. And then really talking about data exchange per se, can we really give a fully federated model wherein only the copy of the data can be stored centrally, or the data remains at the source? You can only view it whenever you would really need. So the architecture has to support a federated, centralized, different types of topologies, depends upon what types of implementation we're really talking about. And then the scale of data growth. Again, we are talking about like a large country like India, where we have billion population. How are we going to really scale and secure that information is again another challenge. The last part is, once we have all of these, how do we really use this data for research or secondary use to really kind of make use of the information that we really have in a secure, de-identified manner? So these are some of the challenges one have to really solve. Now, if you look at Oracle, we've done about 30 plus national level EHR implementations globally. In fact, one of the examples that I want to talk about is Australia, where the entire national electronic health record platform runs on Oracle platform that we really have. It almost covers more than 25 million population data. You can really see that we have like 1.89 billion clinical documents that is being stored in the particular platform. In fact, you can really see the number of health summaries, health notes, number of pathology reports. All of these are totally available instantly for any citizen to view it. Similarly for doctors as well. Almost 91% of the entire Australia's pharmacies are registered. Similarly, for more than 91% of GPs, including the private and the government, both are kind of using this platform, what we call as My Health Record. So you can really see the adoption. I mean, these slides are actually what the government of Australia kind of really published. So these are some of the summaries in terms of discharge summaries, specialist letter, referral notes, pathology reports. All of these are available in a unified medical summary for any citizen or a clinician based on the concern they should be able to kind of access. The other example I want to talk about is Brazil, where we actually kind of solve this problem of patient identification. So they actually have about 300 million patient records. Now, after they implement the Oracle solution, they were able to kind of remove the duplicates. Almost 20% of the records were duplicate. They were all kind of claiming health benefits through the insurance, similar like what we have like PMJ. So the patient identification is very, very important element to it. So as part of this, we have integrated almost 43 different systems, 65,000 plus healthcare providers. In fact, we have like on an average like 76 million transactions that is happening on this platform almost like every month. So you can really see the kind of scale that we have kind of deployed. Similarly for Canada as well, we have very successful EHR rollout for Ontario. It's one of the province in Canada that successfully implemented the solution as well. So we've done similar engagements in Norway, Ireland, even in Singapore as well. So these are some of the examples of what Oracle has done to really make a national EHR very successfully deployed. Now, if you really look at from a solution point of view, what are the key building blocks that is required to kind of address this particular challenge. One is there will be one single common portal. There's a clinician portal or a patient portal. Any citizens can log in through their health IDs. Similarly, clinicians can log in through their DigiDoctor ID through the portal. And then there are different building blocks. The first component is eMPI, what we call as Master Person Index. So this is the component that will identify the patient uniquely without any ambiguity. So it will remove any duplicates. Suppose the same person may have 3 different medical record numbers. How do we really kind of link it with a unique health identifier, thereby there's no duplicates? Similarly for doctors as well, that is what the eMPI will really do. And then terminologies. The incoming data from different hospital systems, they can follow any terminologies. It could be ICD-9, it could be 10 or a SNOMED, but the system should be able to automatically normalize the terminologies. So that's the second important element to this whole HIE, Health Information Exchange framework. And then registry. Registry is really very important thing, what we call as health record locator. If you look at National Digital Health Blueprint, it is talking about federated data exchange, which means that data will remain at source, but you should be able to store the metadata. So that is what this health record locator or registry will do. It will keep track of all the transactions happening across different health systems. And whenever data need to be viewed, you can kind of view it through the registry. And then integration interoperability is very important because every single hospitals will have different messaging standards like HL7, V2, V3, all of the different standards. How do we really kind of convert those data standards into a FHIR, which is being adopted by the National Digital Health Blueprint? And then in case if the states wants to store or build a repository at the state level, then how do we really store all this information in a common centralized clinical data repository? So these are different building blocks that we really need to kind of look at. From Oracle point of view, these are the products that we have, like Oracle Healthcare Master Person Index, Health Record Locator, Data Repository, Terminology Normalization. All these components are deployed very successfully in various large national EHR implementations globally. Now, I just want to show two screens to kind of explain when I talked about longitudinal patient record. This is exactly what is a longitudinal record. You can see the top column. There are multiple medical record numbers, 9848 33009. There is 0010. Then there is 0001. So this is exactly what will happen is when we really implement NDHM. There will be multiple medical record numbers, but there is a one unique identifier, which is the health ID generated by NDHM as well. And the doctors, when they log into this platform,
I will request Mr. Jairaj if you can kindly wrap up in the next 2 minutes. We have to get into other speakers.
Yeah, this is the last slide. Yeah. So you can really see all the consultation notes, irrespective of which hospital the patient goes. The doctors will be able to see all the consultation notes, all their problems, allergies. For example, each allergies could be reported from different hospitals. They can really see all of these. So this is what is the end state we really want to kind of get as part of the NDHM. Similarly, the patients can also view. This is the PHR. They can see who accessed what records. They can see what medication he's taking and what problems, allergies, all of that. So I'll be happy to share if any of you interested to look at this in detail. But these are already reality. There are many countries have already successfully implemented. I think clearly India is kind of leapfrog in that direction to really make very successful, national EHR so that we have a health record for every citizen in the country. With that, I will end my presentation. Thank you, Souvik.
Thank you, Mr. Jairaj, Senior Director, Health Sciences, Asia Pacific, Oracle Corporation, for giving an insightful presentation. And he talked about the 5 key elements of the architecture of National Digital Health Mission and the importance of health information exchange and how Oracle is bringing about a change when it comes to the electronic data of health records. And he has given the example of Australia, Brazil, and Canada. And I'm sure eminent speakers and delegates who are part of this conference today will be interested to know more about the solutions provided by Oracle when it comes to healthcare information exchange. Thank you, Mr. Jairaj, for giving an insightful presentation at the beginning of the first day of Digital Transformation Conclave. The first day is dedicated to healthcare, second day on Digital India, and third day on smart cities. With this, I move on to Professor Ravi Kant. Director and CEO, AIIMS Rishikesh. We know the topic of this panel discussion is leveraging emerging technologies for effective public healthcare service delivery and building resilient and sustainable infrastructure of the future. My question to Professor Ravi Kant will be, when we talk about National Digital Health Mission, how do you think that National Digital Health Mission can take the Indian healthcare story to the next level? And what are your thoughts, and what will be the role of an institute like AIIMS in that? Professor Ravi
Okay,
Kant.
welcome, Souvik sir, and greetings to all. What we are seeing earlier, I was managing a 4,500 bed hospital as a vice chancellor, and we saw what is the problem in, say, obstetric ward. There were 9 Fatimas and 14 Kamla Kumari. And if you want a blood, you can always get confused as to for whom it is meant. And gradually we found that wristband was mandatory in order to survive an onslaught by ignorance. But question is when that patient comes again, or what is happening to the population, what is the trend? You don't know. If you don't know what is the trend in the population, you are not ready to say be for how to manage. And number two, you are not able to deploy preventive system. You are not able to manage at source, maybe in village or in remote center. So they all land up into the tertiary care center, which is avoidable. What we need to know is what is the main issues of the public and how can we prevent it. If we know the trend and we can focus on preventive health, that will be one issue. Second issue is secondary health. In the secondary health, we are finding a lot of people are coming by what you call as a mismanaged soluble problems like diabetes or like other conditions like bronchial asthma, like hypertension. If we can have a complete health program on a periodic basis nationwide, then this catastrophe, we call it tsunami of cardiovascular cases. The tsunami can be prevented if we have the data and care right at the primary health center, but they need to know who was the patient, what has happened, and in a way, when this patient comes to us, we know exactly what was the fault in the system, where something has gone. Now we come to the tertiary care. We are seeing a lot of patients who are coming in tertiary care could have been very well managed in primary health care. And that is the reason AIIMS and major institutions have such a overcrowding. More because the backup system is not there. Once the digital health record system is there, we will be able to say this patient needs this sort of therapy and therefore he need not come to us. That would be another point. So what we are seeing is overall, unless until digital health mission is complete, we will continue to have disasters, we'll continue to have infant mortality, we'll continue to have maternal mortality, we'll continue to have cerebrovascular stroke, cardiac problem as a tsunami. If we really want to prevent that, we need a profile. The profile can be managed right from beginning to end. So apart from treating today, more important is how to prevent. And that data which will be accumulated, because we know we see so many patients. But when you come to world literature among the top 10, top 20, top 30, the Indian literature is not there. And reason is we do not have the data. So the data is equally important. We have seen that in our place, we put Aadhaar as a mandatory, but hidden on all sheets except us. The advantage is when that patient comes again, he will not be re-registered as a second page. So that way the data of how many cancers you have, how many stroke you have, how many heart attack you have, how many renal failure you have, that can be prevented. In order to streamline, in order to deploy limited resources which we are in the health, it's important to take care of from the digital angle, and without that it will not be solvable. So I would say for survival of Indian population, digital health mission is mandatory, laudable, and I would say I salute the Honorable Prime Minister for starting this program. Thank you. Swabiki, over to you.
Can you see me and hear me, the Professor Khan?
Yeah, I can definitely hear you.
Yes, yes, yes. As you rightly said that in this new world order and new way of looking at things, the importance of digital health records will be of utmost importance in coming months and coming years. I'm sure you being a leader in healthcare for so many years, AIIMS Rishikesh will also uh, shift its focus more and more to digital interventions and digital records and how more and more technologies can be
Honestly, right,
leveraged for that.
Souvik ji, right from beginning, with the help of government system, that is the NIC and eSanjeevani, we have been having electronic record. We have got a
Right,
cashless hospital. Nobody pays in cash. Everyone pays digitally. All data is electronic. So we have already taken a lead for last 3-4 years that the data will be electronic, the payment will be electronic, and all data will be preserved. So in your next visit, we will know what has happened to you earlier.
right, right. True, and I happen to know about the digital interventions being implemented in AIIMS, as you rightly said, and quite visionary steps have been taken while building AIIMS, not only in Delhi but other parts of the country. I'm sure Rishikesh AIIMS has done the same thing. They have thought about the future, not only about the present load of OPDs, but what will be the future load of OPDs, maybe 5 years down the line, and they have built those OPDs accordingly. That I know, I'm sure about the AIIMS Delhi, and I'm sure, as Professor Kant has mentioned about Rishikesh AIIMS and how they're using cashless methods and complete with digital intervention. Thanks a lot for that. With this, we had a perspective from healthcare solution provider, with a perspective from AIIMS Rishikesh. But what about the policy part? For that, we have a young, dynamic IS officer with us, Dr. T. Arun, Principal Secretary, Health, Revenue Department, also the District Magistrate of Puducherry, and also handling the role of CEO, Puducherry Smart City Limited. His hands are full and he's handling divergent portfolios, being a bureaucrat. My question to Dr. Arun will be that what is the importance of effective policy implementation when we want to build a resilient, sustainable healthcare infrastructure? And what is your opinion on the importance of digital interventions for healthcare transformation in the new world order?
Yes, sir. Good afternoon, sir, and good afternoon to all the dignitaries. Uh, I'll just start my remark with the National Digital Health Mission, which the government of India is very keenly focusing it on. From the it was part of the national health policy, which was mentioned in that, and it was launched on August 15th. Since the government of India, of course, they want to take it to the all the states, but in the initial level, they want to start at the UT level. I mean, all the UTs were covered, and Pondicherry is one of that as in the pilot project. There are there are a lot of advantages, as the esteemed earlier speaker also said about that, and most of the institute have already into these platforms, and even Jipmer here in Pondicherry is also doing that entire e-pharmacy and other things. At the policy level, there are uh, certain bridges that has to be filled. One, we have to have a very robust mechanism of data collection. So, if you see, 80% of the patients are taken care by the private practitioners, and 15% would be for the at the PHC level. So that is a major challenge for all of us. So we have to tap the private practitioners to come into it, and in that direction, the NHA and has taken a right direction, that through DigiDoctor and all those things has been implemented, and we are also part of it, and we are also doing it. And in this is one aspect. Second is, it has to be integrated to the PHC level. So imagine, at least for Pondicherry, we have enough resources, say the data and all, like we have a good network and all. But in various parts, because earlier I was in Mizoram, I served as collector there for 3 years. Mizoram and all, even getting a normal electricity itself is very difficult in remote parts. So these are the some of the infrastructural issues that has to be addressed. But as a priority, it's a positive step. We have to take it forward. Say number one, we can do at all the discharges that happen in the tertiary care centers. Now only the JIPMER and Premier Institute like AIIMS and all might be doing. We want to do it at every level. Of course, many private colleges, many private labs are also doing it as a part of it, but we can extend to this level. Second, we can go even up to the extent of CHC level. Third would be the all the deliveries. Whenever any AMC comes, they all can be enrolled as a part of this National Digital Health Mission. Whoever comes, as we disperse a lot of other policy incentives like Janani Suraksha Yojana and other schemes which we implement, there also the enrollment of the beneficiaries can be taken. What is the challenge which when we face for enrollment? We do generally when patient comes to the hospital, there would be people may not come regularly. So these are some of the things, and if they don't come, they'll say why should be enrolled. Even that has happened with our Ayushman Bharat insurance also. Many would not take it immediately. They might take it, okay, whenever need arises, we'll do it. But here, since there is no incentive to the individual will feel whenever I go to hospital, I'll take it. So one is tapping the private practitioners. Next is tapping our PHC and other places. Third is involving the community in a very large extent, including creating awareness about the advantages and all. We have to start enrolling them. And one of the method of enrollment is even when they come for any sort of things, even any sort of beneficiary, as I was saying, for pregnancy, for getting ANC, antenatal checkup, there also it can be enrolled. So these all would be it would be part of a larger perspective of getting enrolled and getting these schemes to be delivered through them. And there are other issues that has to be. There was some discussion which has happened. I still remember. Say a person might be having some of the diseases which he don't want to reveal for other things. Say for example, if I have a common cold, I don't want to reveal all my medical history to the clinician. Say I have a dermatological issue, I just come for acne vulgaris, for acne. I did not show my other confidential diseases also. So there should be some sort of a split in the means what all can be shared, what all can be viewed, and the privacy content and other things should also be taken note of it. Because of course the history is very important. Say allergy, known case of tuberculosis, maybe hypertension, diabetes, these might be required for everyone, but not all diseases would be required. So these are some of the policy level intervention that can be done. Second is it would be maybe a unique number would be better idea, no doubt. But what if he doesn't have a unique ID, or if he loses it? Because as we have seen, most of us may not remember our Aadhaar number or any other numbers. So in that case, if anyone wants to have avail such healthcare facility, what all he has to do? So these are the area of intervention that we can look into it. And definitely, and we have to integrate with the insurance also, where be it Ayushman Bharat or any other universal health coverage or any other private health coverage. So these all should be part of it. And so that in that way we have a very robust data management and the mechanism for this, and through that we can definitely deliver a very good this. And I think I have fairly answered your question in that regard.
What you have just said, Dr. Arun,
Hello, I'm not.
actually, I'm just quite excited to ask you one more question before I move on to the next speaker, because you're also handling the smart city Puducherry. Uh, as a policy maker, what is the biggest lesson out of this pandemic in terms of building smart cities of today and for future in terms of healthcare? Dr.
Yeah,
Arun, can you hear me?
yeah. The yeah. Please, can you please repeat it? I could not.
Yeah, so I cannot resist myself from asking one question to you, and I'll give you 2 minutes for that because you're also handling the smart city Puducherry as a CEO. I'm just asking you that the biggest lesson of
Yeah.
this pandemic, not in India but globally, will be focusing more and more on digital healthcare while building smart cities. Do you accept that
Yeah.
point of view as a policymaker?
I yeah, definitely I accept that. And in this regard, in fact, we have established one integrated command and control center. Through that, we have established a COVID war room. Data is very crucial, because in the initial level, we might remember, but over course of time, the way the amount of surveillance happening, the way the contact tracing is going on at a very large scale, the tests are being conducted at a very large level, and distribution of food, taking care of medical care. So all those things would be part of our bigger smart city project. And we are also in that regard, we have established our COVID war room. That is one thing which in the beginning itself we had started it. And this is one area where, same way, I in fact, we can go to a much larger extent, not just COVID, for other diseases also we should have certain kind of a command center for controlling all these diseases. And in fact, with involving the VCRC, we have started with even for dengue and chikungunya also, something like a identification of hotspots, clusters. So smart city is definitely it would really add to the policy level. This one.
Right, right. Dr. Tiarun, that you have rightly said that two, 3 points which you mentioned is first is the data collection. Then you talked about the challenges of National Digital Health Mission, and when we are talking about digital transformation of healthcare in a country like India, we talked about the challenges of connectivity, the challenges of identity, challenges of privacy, and I'm sure the discussion which we're having today and tomorrow and day after will definitely, when we document this discussion, will help all of us to come up with a policy document which can address all these problems, and those problems can be solved accordingly. Thank you so much, Dr. Tiarun, for sharing your thoughts with us in the inaugural of the first day of Digital Transformations Summit. The first is completely dedicated to healthcare, second day on Digital India, and third day on smart cities. But as we all know, when we talk about changing people's life, affecting people's life, it's all about upliftment of people, be it healthcare, be it good governance, be it urban transformation. End of the day, all these things have to be done for people, and that's how we bring transformation in people's life. Thank you so much, Dr. Kiran, for joining us in the inaugural of the first day of Digital Transformation Conclave. I will now move to a very important speaker. Professor Ravi, Director, AIIMS Rishikesh, has mentioned about NIC, how NIC is playing a game-changing role for digital intervention for healthcare. And we have a special guest. We have with us Mr. Sunil Kumar, Head Healthcare and DDG NIC. We welcome Mr. Sunil Kumar. Sunil Kumar, your thoughts on how we can leverage emerging technologies for effective public healthcare service delivery. We know NIC is the backbone of governance in India. So your thoughts on that?
So let me start with the 4 or 5 things which NDHM has, which are basis of NDHM. One is basically we have been developing the systems, at least in government and in private sector also. We have been developing the systems. So, but NDHM is not based on systems; it is based on ecosystems. So we have to take this keyword forward, and NIC we have already taken number of initiatives to go beyond systems and take care of ecosystems. And second important aspect on which NDHM is based is continuum of care. So it's not only interoperability or following the standards. Ultimately, common public has to be benefited from these standards. So that can happen only when there is a continuum of care. So that is the second aspect. I will explain each one of them, how this has been done in NIC. So we have to go a little into the past, and then we have to see how these things have been taken care in National Digital Health Blueprint. And the third thing is standards. So my friend from Oracle has described the 5 layers. I think there are 7 layers. 2 layers are side-by-side layers. One is about standards, and on the other side is basically command and control and communication center. So these are the two important layers which cut across these five layers, and the standard is one of them. And the fourth important component which NHA has taken, NDHM has taken an initiative is consent, which was missing from the presentation. Presentation was not carrying that five component which and that consent framework is very important, which was missing from almost all the health application which were developed either by NIC or by outside NIC. And the fifth component is data hubs. I think the most important components, interoperability, that electronic data exchange is not possible without these data hubs. So let me go a little deep into the NIC, what NIC did in past 10 years, and how these 5-6 components, including health ID, came into picture. How NIC contributed in this, and NIC has been part of this creation of this National Digital Health Blueprint. Madam Neeta Verma was on the committee, and I was working with her in framing those blueprint. So if I go into past, in 2010, Ministry of Health and Family Welfare basically initiated one project called Mother and Child Tracking System. Now, this was again a system. Now, it was expanded and formed as a part of the ecosystem. So, what are the other components? How it expands beyond this mother and child tracking system? So, it was extended to Janani Suraksha Yojana. It was extended to payment to the Janani Suraksha Yojana. So, PFMS, it was integrated with PMFS. So it was integrated with a call center. It was integrated with maternal death review. It was integrated with child death review. It was integrated with Kulkarni and mobile academy systems. So it goes beyond mother and child tracking system. So it was realized by ministry and by NIC that we cannot use only MCTS. We have to go beyond that, and that is what the ecosystem is. So apart from this, then another initiative which was taken in 2012, that is NICSHE. See, TB basically, this is NICSHE is basically electronic basically monitoring of the TB patient and their electronic health record also. So the effort was made that MCTS and TB, any mother who is having TB, they need to, their electronic record has to be interoperable. So with this kind of questions, so another thing is basically we have to come. Ministry came up with Electronic Health Standard 2013, which were further revised into Electronic Health Record 2016. Then metadata and data standard for health sector came into picture. So National Digital Blueprint has not come one fine day. There were basis for that, because we have been developing system, ministry has been developing system, private sector has been developing the system, states have been developing the system. This, when ministry want them to integrate, want them to exchange the data, so exchange could not take place. So then there was a realization that we should have standards, we should have some blueprint through which we can electronically exchange the health record from one place to another. And same is the we have been working with the National Health Authority on beneficiary identification system. So it is again an ecosystem. It has gone beyond NHA. It is integrated with the ration card EPDS system. It is integrated with state. It is integrated with the state databases. It is integrated with the Aadhaar. It is integrated with the other component of the state governments. So almost all the health systems which were developed by NIC, they have gone beyond the scope of the original scope. So it becomes a part of ecosystem. So we have in MCTS, mother and child tracking system, which were upgraded to RCH, reproductive and child health. So we basically complied this system RCH with the electronic health record standard, which were notified by uh, uh, ministry. So in this we have made them HL7 compliant. We have made them compliant with SNOMED City, with ICD 10. So this system now is interoperable, is ready for exchange of data with any other health system. So we have developed e-hospital, we have developed ORS, online registration system, e-blood bank. All these systems, they are now integrating, we are integrating with 5 components of NDHM, that is Digi Doctor, Health Facility Registry, Health ID. Soon, within 10-15 days, we will be launching e-health ID in 2 hospitals of Chandigarh. So we have already integrated. We have already integrated Health ID, which have been created by a good amount of citizens of Chandigarh. So we will be providing them interface through which these Health IDs will be integrated with e-hospital, which is implemented in 2-3 hospitals in Chandigarh. So but we have been working, and we have experienced that there was a need for that. Otherwise, there was no agency who has to take care of these master data, especially DigiDoctor, the national doctor the database, which was earlier maintained by MCI. Now it is being available through APIs, so that it can be integrated with various health systems. So what I'm trying to say is, there was a need for NDHM, and there is a need to integrate these systems with various health systems, whether it has been developed by NIC or by state government or by private sector. Private sector is also supposed to join this initiative of the government, so that there is a continuum of care. So if the record is maintained by government or by the private sector, the data is interoperable, and it can be viewed by private doctors as well as by the government doctors. So another thing is, basically, if we see, RCH is basically is a system which cut across many sectors. Let me explain in 1 minute. Basically, when a child is born in any of the health facility, so it say BCG is applied. So immunization starts from there. So every child, when it is born, it has to have a basically health ID. So it has to be seeded into the respective system. Then it basically, then when the child goes to Anganwadi, then this data, which is of child data, the electronic health record of that data should move from health to WCD. Now, if a child becomes 6 year or above, this data electronically should go to education, school system. From school system, it should go to basically, so from cradle to grave. This system, RCH, is already integrated with birth and death in Karnataka. That is done by NIC. So what I am trying to see is this NDHM, if implemented, then it will be integrated across the. It will touch upon all the stages of life of a common man. That is what my views on this. Thank you.
Thank you, Mr. Sunil Kumar, Head Healthcare and DDG NIC. And you talked about the importance of National Digital Health Mission. You said that is the need of the hour. NDHM is the need of the hour. But you also said that a very interesting point that it's not only about system, but about the entire ecosystem to make NDHM a success. And you have said that it's time that we ensure that the integration of applications are happening effectively for making National Digital Health Mission a success, and what NICs have been doing over the years and what NIC is planning to do in coming months and years. Thank you so much, Mr. Sunil Kumar. Let me introduce you the keynote speaker for the inaugural of Digital Transformation Conclave Healthcare Track. Let me introduce you Dr. Nitin Madan Kulkarni, Principal Secretary, Department of Health and Family Welfare, Government of Jharkhand. Thanks, Dr. Kulkarni, for joining us today. I'll request Dr. Kulkarni if you can unmute yourself, please.
Good afternoon. I hope I'm audible.
Yeah, you're audible, sir. Yeah. Can you hear us, Dr. Kulkarni?
Yes, yes, I'm very much hearing you.
Okay, I think there's some glitch in your video, maybe because of the connectivity issue. Thanks for joining us, Dr. Kulkarni. My question to you will be this. Let me also inform you this is a 3-day National Virtual Digital Transformation Conclave. First day has been dedicated to healthcare, second day on Digital India, and third day on smart cities. And we have more than 70 plus speakers for next 3 days who will be joining us in various sessions. And we also have been got registration of more than 1,000 delegates for this 3 days. With this, let me ask you, Dr. Kulkarni, what are your thoughts when we talk about leveraging emerging technology uh, for effective public healthcare service delivery and building resilient and sustainable infrastructure of the future when we talk about the healthcare ecosystem, especially when we are living in a pandemic and new world order? Your thoughts on that? Dr. Nitin Madar Kulkarni, the keynote speaker for the inaugural first day of Digital Transformation Conclave. Over to you, Dr. Kulkarni.
I hope I am audible and
Yes,
visible.
yes. Now it's all okay.
So now I can
Yes.
start actually. So this is the first protocol of participating in today's meeting, that you have to ask whether you are audible and visible. Then the rest thing goes on. So very warm good afternoon to all the participants. And as we traverse through this pandemic, and I think most of the states in the country are now able to reach a stage where they can relax a bit. I won't say much more, but still a bit. And the issue seems to have been localized to an extent to certain particular pockets of the country. So I think the figures are also quite promising for last at least 1 week. And with this type of trend, I think we can expect that we may soon return to what we used to define as normal rather than this new normal. So I will just like to say that the most important thing with this pandemic has done is to bring the technology to the forefront as far as healthcare is concerned. Earlier, always technology was there, and there were a number of initiatives taken, but they were mostly localized and mostly short-lived. But now with this pandemic, virtual consultation is the norm. Now everyone wants that, even the patients are interested in it. Earlier, when we used to ask the patient to go for telemedicine, they will be a bit reluctant. But now, at least for common ailments, nobody wants to go to the hospital. That's good in a way because it reduces a lot of burden on your healthcare systems, and they are left free to cater to the more serious cases. Public health care has come to the forefront because of this pandemic, because earlier we always used to sort of, most of us so-called elite at least, used to look down public healthcare systems. They used to feel that this is something which is just immunization and some pregnant care for some pregnant women, particularly in rural areas. But with this pandemic has proved one thing, that when it comes to the crux of it, finally it is the same public healthcare system which delivered and which not only delivered, I will say delivered to a much greater extent and to a very in a very nice fashion. That is the reason that today, even I can just say the example from my state, in a place like Jharkhand, where there is a great shortage of manpower, there are interior areas, there are hard to reach areas. Even we were able to handle the cases right up to the every nook and corner of the state. And technology is going to play a great role in the healthcare delivery system. Earlier, technology was just limited to sort of some new discoveries, some minimal surgeries, some scanning and diagnostic techniques. But now it has to look much ahead of it. I think just I was listening to NIC, Mr. Sunil Kumar, and I think he has put in the right perspective. What with the launch of National Digital Health Mission, at least the things which are scattered throughout the various programs are getting integrated. Hospital, DG Hospital, then various direct transfer schemes, they will all get integrated in this particular mission. And I hope that will bring a sort of a consolidated digital approach for the entire country. Most important issue is maintaining creating the health record of the patient. If I travel from one part of the country to the other, I have to carry my all the records, but with e-health card, I think that part will be taken care of. And wherever I go, my diagnostics and my earlier reports, my previous treatments will be available for the next doctor to see on easy on demand. Obviously, there is a chances of duplication of treatment or some medical errors will also be reduced because of this. Most important technological intervention which is taking place, and it has been implemented in some hospitals, particularly this is being tried by use of artificial intelligence. Pre-created algorithms are there, and these algorithms are diagnosing the diseases in their preconditions. Particularly true for cancers. This has been tried by Google. Some algorithms have been developed, and it has been very detection of the likely cases of the breast cancer. And I think this pre-detection of the diseases is the one thing, particularly considering our NCD load, that is non-communicable diseases. If we are able to have at least the idea that this is the vulnerable population which is likely to lead to diabetes or hypertension or some type of cancer, I think that will be a great boon public, and it will reduce a lot of future burden on the public healthcare system, which normally comes when the same case comes to you as a patient, and managing it becomes a big task in itself. Another new intervention which I was seeing was about this crowd scanning. Now the devices have come where they are scanning you throughout in the crowd, and again taking you out, saying that you are likely to be susceptible. This thing is working for COVID, but subsequently this can obviously be replicated for other diseases. Another important initiative which has, earlier we were not much cared. I don't know how many of us ever had oximeter at our homes, but now most of us are having it. Similar is the condition of many other healthcare devices, particularly wearable devices, what you call, like I have this smartwatch which counts my steps and my tells me my heart rate and my calories, etc. I think this awareness of these wearables and monitoring your own health, I think this is a great behavioral change, and it is coming through all the various mobile apps as well as through these wearable devices, and it sorts of encourages you, it nudges you to a particular behavior. So these initiatives will definitely go a long way in improving the health of society in the long run. Another important point I will like to make, this technology is most important is the connectivity. Connectivity in the sense patient is somewhere else, diagnostic is sitting somewhere else, and the doctor is sitting somewhere else. So remote monitoring of the patients, remote monitoring of the devices, now it is possible. And courtesy to COVID, because you cannot touch the patient and you are supposed to stay away from the patient, all these initiatives became important, and they became crucial in fact in managing the patient. So you have now virtual consultations, you have chatbots and whatnot, but at the same time that personal touch, which is the most crucial part of any medical intervention. Whenever we go to a doctor, it is said that it is the personal communication of the doctor which heals the patient, not the medicines. So that part we will have to look into it when we go shift to this entire digital mode, how to ensure that the patient feels the same type of sort of connect or same type of engagement with the doctor. Similarly, home-based diagnostics is another area where things are really looking up, and now we can have a system where some person just comes to your place and you get all the results. Obviously, you have those, all the diagnostics are available digitally now, so you can get it done at any place, and the interpretation can be done by a person sitting in Hyderabad or Bangalore, any expert. So this reduces the burden of particularly having the specialist doctors, particularly in backward areas. It's a big issue to have the specialist doctors. They are not available also and not willing also. So I think this digital health mission will help us a lot as far as this part is concerned. And we are really looking at it to launch so that it is launched earlier, and then we can really integrate all our digital systems and help the patients as well as, because particularly public health, the main concern is the access to the healthcare system, and second concern is delivery of the healthcare system. If we are able to address both these issues in the quick time, I think most of our communicable disease problems and the non-communicable disease problems will be taken care of. To start with, I wish you all the best. We have a long sessions ahead, so I wish all the topics will be nicely covered by the experts, and you will carry on with some new initiatives as you are doing earlier. And please come out with the proper publication of the special comments coming from the experts, so that all can use it whenever required. So I wish you all the best, and thank you very much. Namaskar.
Thank you, Dr. Nitin Kulkarni, Principal Secretary, Department of Health and Family Welfare, Government of Jharkhand, who is at the helm of affairs when it comes to healthcare in the state of Jharkhand. And we have been personally knowing his work in the grassroots of Jharkhand to bring about change in the healthcare spectrum. And to sum up what he has said, that he has obviously said that National Digital Health Mission is a step in the right direction, but he also told us and also reminded us that this pandemic has again shown us in a very important way the importance of public healthcare and why the public healthcare needs to be maintained, need to be addressed to. This pandemic has proven that. And a very important part, which according to me is a very important one, when when we're talking about technology, we have to also ensure the infrastructure of bringing those technology to the marginalized or the last mile, and their connectivity is going to be an important too, important role, and those needs to be addressed. I'm sure our National Digital Health Mission and all similar such programs will help to create a robust, resilient future healthcare ecosystem for India, especially out of the learnings of this pandemic and in the new world order. Thank you, Dr. Nitin Kulkarni, Principal Secretary, Department of Health and Family Welfare, Government of Jharkhand, for delivering the keynote address in the inaugural of the first day of Digital Transformation Conclave, being organized by Department of Electronics and IT, Government of Orissa, hosted by Mohdawat Smart City Limited, along with GovConnect and APAC Digital News Network. Let me also thank our partners, supporting partner MeitY, powered by partner Hewlett Packard Enterprise and Intel, cloud technology partner Oracle, storage partner Western Digital, and technology partner Globus, and collaboration partner Avaya. With this, we move on to the next speaker. Let me introduce you Dr. Shafqat Khan, Officer on Special Duty, Department of Health and Medical Education, Union Territory of Jammu and Kashmir. We welcome Dr. Shafqat Khan. Dr. Khan, your thoughts on the importance of building resilient and sustainable healthcare infrastructure by using National Digital Health Mission, emerging technologies, and more digital intervention. Your thoughts from Jammu and Kashmir.
First of all, my greetings to everyone present in this panel today. And I would certainly want to highlight the importance of the National Digital Health Mission. And in my understanding and belief, this has been one flagship program launched by the Honorable Prime Minister of India as a dream project. And this dream project of Ayushman Bharat and extended healthcare insurance to the downtrodden and the overall population of this country. I understand that the National Digital Mission will be the most appropriate mission, which will now cover the baseline healthcare needs of the citizens of the country. Uh, you will have to understand one thing, that the healthcare comes basically from the primary health center. It is the basic node of, and it should be the first basic node of contact of a patient. It has to have a referral system where a person needing specialized treatment should go up the ladder to a secondary or a tertiary care hospital. As some of the panelists discussed, that they are launching it in Chandigarh and other tertiary care hospitals, the digitization of the records of the patients, the digital record library or archives. Uh, I understand one thing very clearly, that the beginning of the entire process should start from the primary health care level, and keeping in view that the tertiary care hospitals have already have their repositories, they have their own digital systems, they are electronically equipped. Most of the tertiary care hospitals have their own telemedicine facilities. They have gone a step further in augmenting and providing telemedicine services to the district level hospitals. I'm talking about my state, that UT, that we have taken our telemedicine program a bit further to the district hospital. But I have had this understanding always, in the health needs of the people of this country, that this digital mission or any endeavor in securing the health of the people of this country should start from the peripheral healthcare. That is the difficult terrains. Look at J&K. You have highly difficult terrains, inaccessible areas of the Union Territory, where healthcare is very difficult to be administered in, especially the winter months. Second, very important thing Dr. Nitin said was about the internet connectivity. We should have a seamless internet connectivity to to all the areas of the country, to the last primary health center in the border areas. And this is very important in terms of sharing of data, sharing of investigations, sharing of other information about the patient from the primary level to the secondary level. So, in my understanding, we will need to, number one, have mapping of the primary health centers, secondary centers, even to the sub centers, which are numerous in number. In our political dispensations, we used to have a primary sub center, small center in areas where sometimes it was not needed. So we'll have to map our healthcare facilities first, rationalize their presence, the number of healthcare centers at particular areas, suppose in a district which is say border area. Then we have to rationalize how to strengthen the primary healthcare center, where it should be the interactive node, the first node for a patient to come get registered. In between, I would also like to recommend that the National Digital Mission Platform should be integrated with the Aadhaar. It should be seeded with the Aadhaar, with the other cards which are available with us, where we could have a biometric presence of the person in that card, so that duplication is avoided. There would be the chances of false claims, of having the same patient registered 8 times, could exponentially go lesser in number. And then we have to understand that there are health needs in the primary healthcare apparatus of our healthcare system, where we have to look at the needs of health of children, especially the girl child, the adolescent young boy, we have to see the psychological health of children. We are going through a very, very hugely difficult phase. Uh, uh, in fact, one of my friends called me from Jammu in the morning, and he said his 22-year-old son got positive with COVID, and suddenly has started getting bouts of hypertension. You know, and this hypertension is taking a toll on the mental health of the boy. He's seen with a blood pressure apparatus all 24 hours of a day, checking his BP, 10 times a day. So we will have to look at counseling apparatus. We'll have to look at a very robust apparatus at the primary healthcare level, where even in a city, it is not necessary that I walk into AIIMS if I am living in area of Green Park or Safdarjung area in Delhi. I can walk into a primary health center first, get assessed, and if need be, referred to AIIMS or Safdarjung or any tertiary care hospitals. So I think the primary health care will be the basic node of strengthening our healthcare. We go immediately to tertiary care hospitals. It's a habit that we start from AIIMS. With all respect to Dr. Ravi Kant, Director of Rishikesh, I appreciate the work which is being done in AIIMS, Delhi, AIIMS, Rishikesh, and elsewhere. But I think we'll have to strengthen our healthcare apparatus to the primary healthcare level. Number one, provide seamless internet connectivity, registration of the digital data, digital, whatever form you want to keep it in the digital form or the PDF format. You have to have the patient's entry level information present on a storage device at your primary health center. Then you can go higher up into the existing network of hospitals which you have at the district level, then at the tertiary care hospitals, and the variety of private care hospitals across the country. We can share this on a combined database. Then somebody was talking about security issues. I appreciate, yes, security is a concern in healthcare, but why not have a CIBIL type system like the finance people have? You have a CIBIL rating. The same way, somebody can come, put in into his health ID and everything into a format, and immediately find out his health status. So I think developing a robust digital network or a platform in healthcare is very important. Jairaj had a very wonderful presentation. I really congratulate him for having given us an in-depth understanding of how things should be. As he rightly said, there should be a federal health information archive, which should be stored either in physical places or in the cloud form or wherever, and it can be a huge repository of our human health resource in the country. And I think when we will be able to have this resourceful information present on a base somewhere, we will be able to decide the future of this country. We will see how healthy our country is, how we are going, ahead of the other countries in the world. And I am sure, with the initiative of the Government of India and the Honorable Prime Minister, this vision will be accomplished, and every government is working very aggressively on it. J&K was 32, suppose IMR some years back. Now we are at 24. We are doing so good in terms of infant mortality rate. So we have strengthened our pediatric neonatological healthcare setup. We are taking it to the district level now. We are having a neonate and a pediatric healthcare unit at the district hospital level, so that any person coming from a difficult area should straight away not reach the children hospital at Srinagar or Jammu, but he should be able to go to a primary health care facility or a sub-district hospital or a district community health center in the district within reach of his, so that the child can be saved, or the maternal mortality rate. So I will close my session with saying that we will have to start the digital information linkage from the primary health, from the secondary care centers, and take up to the level of higher institutions, where we have already done some work. And I think I would want lastly to say one initiative that which is very important to be understood. That is that we'll have to develop an ecosystem, as rightly said by Mr. Ravi from SeMT and NIC. Sorry, that the ecosystem will comprise of an entire, understanding of where our digital data needs to be captured, how this ecosystem will envisage into the secondary healthcare, the tertiary healthcare, and how the information can be shared with the private entrepreneurs in the country. But anyway, what I understand is all what is going to be done is for improving governance. It is a smart initiative. All digital initiatives are smart initiatives, and I understand that we will soon see smart hospitals, smart primary health centers, smart district hospitals by having all this. And let me add up that we are starting a universal health insurance policy in J&K. Honorable LG is going to launch it in a day or so, where we are ensuring the entire state, because we had Ayushman Bharat had covered only around 30 to 40% of our socioeconomic caste census based people, but we have gone much higher. That the government of India has been supportive of a universal healthcare program, which will envisage and cover the entire population of J&K, 1 crore 20 lakh people, and every household will be insured to a 5 lakh ceiling, free of cost. The card will be issued the head of the family, including all members of the family, old, pre-existing diseases, everything included. And this great initiative with the help of the government of India, we are going to do very soon, is going to be a milestone in the healthcare of J&K. And with that, I thank you all for listening to me.
Thank you, Dr. Shafqat Khan, officer on Special Duty, Department of Health and Medical Education, UT of Jammu and Kashmir, for highlighting the importance of taking telemedicine system to the district level hospital. If I'm not wrong, usually you said that. Also, one important point you have said that the integration of NDHM with Aadhaar, that will also help, and also strengthening the primary healthcare system or infrastructure in those areas, especially where those areas which are inaccessible. There are a lot of problem reaching out to those places, and there that technological backbone has to be there, the connectivity has to be there. And as you have said, that all of this, once it's done, National Digital Health Mission will surely be a game changer for this country's healthcare ecosystem. Thank you, Dr. Shafqat Khan. So we have a perspective from Uttarakhand, we have a perspective from Jharkhand, we have a perspective from J&K, we have a perspective from industry leaders also. And now we'll have a perspective from West Bengal. We have with us Dr. Abhishek Roy, Head SeMT Department of Personal and Administrative Reforms and eGovernance, Government of West Bengal. Dr. Roy, your thoughts on how leveraging emerging technologies can be effectively used for public healthcare service delivery, and what are the major initiatives being done in the state of West Bengal in this spectrum?
Yeah, very good afternoon to all the dignitaries and all the. There's an echo. It's clear? Sound is clear?
Yeah, it's clear. It's clear. It's clear. Yeah.
Hello. Yeah. So, very good afternoon to all the dignitaries. I would like to basically touch upon the 5 pillars of NDHM, and I'll then try to correlate with the practical examples of some applications which have been already launched in West Bengal. So, as already told by your NIC colleague, that NDHM is the need of hour, and the issue is not of the system, but of the ecosystem. So, with regard to this health ID, we have the 5 main pillars of the NDHM. With regard to the health ID, actually we started an online OPD booking. So, in all government hospitals, so OPD, there's a huge queue in the OPDs. People used to stand from 6 a.m. in the morning to get the OPD tickets and get them consulted through government doctors. So we started an online OPD booking. The only concern was that for the online OPD, they can book it through mobile also. For the online OPD, it was any government ID document. And the fees was also waived off. Earlier there was 2 rupees was charged for any OPD consultation in government hospitals, but for the online OPD that was also waived off. You need to just have any ID document which needs to be either SMS or to book through an app, and then you can come down at your designated time and go and get your consultation done. But the practical scenario was that no one was turning up for the online OPD. Even we created some kiosk in the hospital so that they can book directly. If they don't have mobile, if they don't have app, they can just key in their one ID document, and then they can print out the OPD ticket, and then they can go and get them treated. So I'm telling you because people are very resilient in sharing the information. Even if it is free, even if it is bypassing the queue, they're not ready to share their any ID documents. So the health ID concept is there. So for the health ID, again, that issue will be there. So if you again create one more health ID, one more thing, the people will then try to hide if they'll go at multiple places. So there are patients who approach 2 different hospitals to get diabetes medicine. Diabetes medicines are costly, and normally it is given for the entire month. So they approach 2 different hospitals and take away medicines, and they don't know what they do after that. So these scenarios are there. So if you go for a particular health ID, these things are more suitable for mere insurance based treatments. Whenever they'll be getting a insurance, basically the Ayushman Bharat or any other insurance schemes launched by the government, for that definitely they'll give all the documents. But when it is coming down to these types of scenarios, so they'll not be showing any document. They are basically signing up, they'll try to hide everything. So the significant challenges of this NDHM are basically the ethical issues, social stigma. So people, as Dr. Arun also told, that what all can be viewed, the people try to hide the other things and all. But there's one saying that to the doctors and to the lawyers, we should not lie. We should give them all the informations. But we still have that social stigma. Such issues will crop up. So instead of creating one more ID, my idea will be, as already told by Dr. Shafqat, that linking with Aadhaar is a very good idea, and this cradle to grave idea. The cradle to grave, we have started one application basically for birth certificate. We are putting the birth certificates on blockchain, and the idea is that the birth certificate will be tracked throughout the life cycle of the person, from the cradle to grave, with respect to the education and all other job and everything. So social status we can get from the parents data for the child, and similarly it will be tracked throughout his life cycle with respect to career. Similarly, this cradle to grave is a good idea for health ID, but we need to integrate. We had voter ID, we have Aadhaar, we have creating one more ID. So it's better to integrate and put only one health ID, so that the entire life cycle can be managed. Now coming down to the HFR. So with respect to this HFR, basically this health facility register. So I'll give an example. We basically started with the Clinical Establishment Regulatory Commission, and an online application was made wherein anyone having any issue with any private hospital or any government hospital also, they can place a complaint against the hospital, and the entire processing was online. The complaint will be sent to the hospital authority, and they are supposed to revert back within a certain period of time, which will be shared back to the person. And then finally it was a quasi judicial procedure when we launched it. And this application was directly linked with the clinical establishment license. So we were populating the data from the establishment licenses. But when we launched it, what we found, that there were many hospitals, small nursing homes, clinics that were not registered at all. So when summons were issued to them, they came back to us. They told, okay, fine, I am ready to pay whatever fine you impose on me, but please give me a license. So the point here is that I want to make a point here, that in the rural areas there are many such health facilities available which are not registered, running illegally, and we don't know. Suppose if I'm in a rural area and if I fell sick, so I'll go to the hospital. I'll never ask, okay, please show me your ID card or license, or whether you are regularized or not. We'll just go and get the treatment done. So this is a very big issue to getting all the health facilities recorded. Now coming down to this Digi Doctor. So for the Digi Doctor, we know in India there's a very shortage of doctors. There are many Jhola Chhap doctors available, RMP, there's then alternative medicines, all sort of things are there. So people initially we are basically worried about the rural areas. So people basically will go to the nearest available person. He may be an RFP, he may be a SOCLAM. In cities like Kolkata also, there are people who give entire allopathy medicine, but they don't have MBBS degree. So in many, because people don't go and ask. So these things are there. How to regularize this? And if you really regularize it, then there will be a shortage of doctors. So this is one of the key area of concern. Then with regard to the PHR, where this consolidation and privacy is a big issue. We basically started just for the, as we know, for NDHM, the data and digital data is the main concern. So we started e-prescription in all our hospitals around 4-5 years back. But the problem was that none of the doctors are willing to type. So they don't want to spend time on typing the prescription, writing anything or whatever the thing. Then we came back with solution that, okay, you don't type, we'll try to automatize, we will give you some drop downs, and from the drop downs to select whatever you spell out, what all are the generic things, so that everything will be available from drop down, and then there'll be one small screen where you can write whatever you want if it is something different from that. That also failed because doctors are not willing to use the drop down button also to minimize the time. So then we've started a new thing, basically with respect to the emerging technology. We've started one voice-based e-prescription. So in that case, we're trying to bring in all government doctors onto that platform, so that if they talk, the entire thing will be converted into a digital data, and an online e-prescription is generated. The point here is that unless we digitize whatever is the prescription, because the handwriting of the doctor is the right, and in most of the hospitals, if you go there, they just scan it out. So reading that is a junk for me. A scanned picture is a junk for me. It has to be in a format. So that's why we need this entire thing in a digital data format. But who will enter it? So we cannot have medical transcription or other people who will just go and read the handwriting and write and then digitize the data. That's why e-prescription is the key. And since the doctors are not willing to type or all those things, so we have come down with a voice-based e-prescription. This is the emerging technology thing which we are trying to incorporate. Now, with regard to this COVID pandemic, we have initiated one free this video consultation platform. So this in this video consultation platform, doctors are then treating through a video consultation. They are writing in the blogs, and a prescription is getting generated and being sent to the patient in real time. So, but there are certain guidelines, but those telemedicine guidelines has to be more stringent. What all things are there? The prescription, because the prescription which is being generated does not have doctor's signature. It's a generic thing which we have tried to maintain those things. So what is the acceptability over a period of time? So these things are there. Then the main issue comes down with the consolidation. Hospitals are basically trying to digitize the data, and then they are basically scanning it and keeping it them, but they are not willing to share it. So the point here is that even the inadequate record keeping in public hospitals. In my case, I'll give an example. Most of the doctors, most of the hospitals are not willing to share the entire treatment history. They try to hide, they try to manipulate. So they will not be willing to do everything in real time. There have been many cases where the the bills have been escalated. They manipulated at the end of the day. So these things are the primary concerns. How to integrate, and mostly, particularly with respect to the lower level hospitals. I mean to say, unorganized sectors, where basically the biggest challenge will be to bring this small hospitals, small clinics. How to bring in? We can bring the big companies like Apollo and others to use our things. Basically, voluntarily, some people have already accepted. But the issue is with fragmented private healthcare market and some non-profit corporate hospitals. So how to force them for this digitization? Unless we integrate, it is very difficult. Now coming down to the data part, we all know there's a high probability of data breach. So data ownership, data normalization issue, data collection, storage, and transmission challenge. So during this transmission, whether there's a data theft or not, illegal data selling and data theft. Because in COVID times, COVID has become a pandemic, just like people are trying to hide their positive results and all these things. So thanks to ISMR, they are publishing the reports in online and all those things. But many people are trying to hide their COVID positive things and other things. So similarly, they'll try to hide
Dr.
a lot of other.
Doctor, I'll just intervene and request if you can kindly wrap it up in a minute because we have to start the next session after this. So if you can kindly wrap it up in a minute.
Yeah, okay. So the last part is that this data quality issue, this duplicate data and inconsistent data formats, inaccurate data and excessive data, and the poorly defined data. And the other thing is maintenance of records and their completeness. So there have been many cases. In fact, 2-3 labs have been sealed because they have given COVID positive report to a COVID negative people. In West Bengal, the Suraksha diagnostic have been sealed because we audited and found that there around 200 plus people were given a COVID positive result, but it was COVID negative. Then they told no, it's a typographical error. So how to control those things? This all from my side. Thank you.
Thank you, Dr. Abhishek Roy, Head SeMT, Department of Personal and Administrative Reforms and eGovernance, Government of West Bengal, for joining us in the inaugural of the first day of Digital Transformation Conclave. The topic is leveraging emerging technology for effective public healthcare service and delivery and building resilient and sustainable infrastructure of the future. Before we wrap up, we have a question from our audience. I'd like to ask Mr. Jairaj from Oracle. If you can please quickly give an answer to this question in a minute or so. Data interoperability is the biggest concern in healthcare today. How do you deal with this, especially keeping in mind when you're talking about national digital health vision? Quickly, 60 seconds you have in your hand.
Sure. So certainly, I think one of the major problem is we cannot solve all the things at one shot, right? So that's why the government has come up with something called minimum clinical data set. So the focus will be on the minimum data set, which we need to identify, and that is the one that we need to make sure we're capturing electronically. And the backbone architecture of the NDHM platform is actually on the Health Information Exchange. That has the ability to convert data. Even if you send a non-standard data, it can automatically convert into a standard format. For example, like fire has been notified as a standard which we need to kind of store information. The incoming data is, for example, like HL7, V2 or V3. Automatically, the solutions can convert into a fire format. So there are solutions available which can pretty much like take care of the siloed information exchange and also the terminology normalization that I talked about earlier in the presentation. So these issues are already solved. I think the key is to focus on the minimum data set and how do we really make it available across, for both EHR and the PHR platforms.
Thank you. Thank you for being crisp and short. And I'd like to thank all our esteemed speakers who are part of this panel on leveraging emerging technologies for effective public healthcare service delivery and building resilient and sustainable infrastructure of the future. I thank Dr. Nitin Madan Kulkarni, Principal Secretary, Department of Health and Family Welfare, Government of Jharkhand, Professor Ravi, Kant, Director and CEO, AIIMS Rishikesh, Mr. Jairaj, Senior Director, Health Sciences, Asia Pacific, Oracle Corporation, Dr. T. Arun, Principal Secretary, Health Revenue and District Magistrate, Puducherry and CEO, Puducherry Smart City Limited, Sunil Kumar, Head Healthcare and DDJNIC, MeitY Government of India, Dr. Shafqat Khan, Officer on Special Duty, Department of Health and Medical Education, Duty of Jammu and Kashmir, Dr. Abhishek Roy, Head SeMT Department of Personal and Administrative Reforms and eGovernance, Government of West Bengal. Thanks to all of you for joining us in the inaugural of the first day of Digital Transformation Conclave, hosted by Department of Electronics and IT, Government of Odisha, hosted by Moderator Smart City Limited, and organized by Gov Connect and APAC Digital News Network, and also supported by Hewlett Packard Enterprise and Intel, is powered by partner with other partners like Oracle, Avaya, and Western Digital, and supporting partner NIC. With this, we move on to the next session on role of emerging technology in helping the healthcare system fight with pandemic and how COVID-19 has changed the Indian healthcare technology landscape. Way forward, do join us at 4 p.m. for the next session. Thank you so much.
Thank you.